So it is my honor to introduce the moderator for this general session. She lives here in Colorado, and she is on the faculty of the University of Colorado and is a professor of medicine, Dr. Lisa Forman. She received her medical degree at the University of Pennsylvania and continued to complete her residency and training in gastroenterology fellowship during this time, and she has obtained her master's clinical in epidemiology. Lisa, I am going to give you the stage.
I'm glad there's not a podium here because I usually am too short for people to see me, so this is good. Just want to thank, before we start, the organizers of this meeting, and I don't know if Ricky is listening, but I've been lucky enough to be involved with PSC Partners for 20 plus years or so, and it's really such an amazing organization, and this meeting is really like unlike any other meeting that there is in the country, and it really is a testament to Ricky and really show how things change because of you, and hopefully you feel that we listen to you and we take your concerns, and we've made a lot of progress, and we'll hear today some of the things because of you, some of the research that we're going to be doing. So again, thank you very much for attending. Thank you for letting me be a part of this meeting and as part of this organization. So on that note, we kind of have like a potpourri today in terms of the different talks. We're going to hear from a patient. We're going to hear about dealing with some fatigue and symptoms, and then talk about some research, and then again, a panel discussion at the end. So I am going to start with Matt Hodgkins, who's a PSC patient. He was diagnosed with PSC 10 years ago while he was in his early 20s. And to get more involved with PSC, he began volunteering with the PSC Partners Canada communication team in 2022, and he joined the board of PSC Partners Canada in just this past January. He is passionate about patient participation in academic and clinical research to further the search for a cure. He's participated in 2 PSC clinical trials, so thank you, Matt, as well as numerous other academic research initiatives, both for PSC and ulcerative colitis. And he lives in Edmonton with his wife and his new daughter. So.
Got it. Good. Thank you very much, Dr. Forman. As PSC patients, we're no stranger to dealing with pretty complex emotions. There's one feeling that's always aggravated me a little bit more, and that's this unwelcome sense of powerlessness. We can't control the cause, can't control the symptoms, can't control the progression, even the timing of appointments or procedures. One way I've found to help reclaim a sense of agency is by participating in research. Sometimes you gain rather interesting experiences. Take, for instance, one of the first studies I participated in. This was a study looking at the use of prebiotic fibers in helping IBD. It was easy enough. It was just mixing a pack of this powder into a glass of water, drinking it once per day. The problem was I was in a university course at the time that had a study tour component. We were traveling to a couple countries in Asia. Meaning, and I wish I was making this up, I had to take scantily marked foil packets filled with a fine white powder through multiple international airports. Should I get asked what this mystery substance was, because it was double-blinded, I would have to say, I don't know. Fortunately, I didn't end up in a Thai prison, and I could be here this weekend. Now, evolving your mindset can take time. I wasn't nearly as positive as I am now. I remember in 2011, before my first GI appointment after getting diagnosed with UC, I was kind of weighed down with worry, thinking, please don't ask me to be part of a study. But I've made the shift, and I'm glad I have. Then when I was diagnosed with PSC in 2015, there was no active research in my area or clinical trials recruiting, let alone across North America at the time. Flash forward in 2020, I participated in my first clinical trial, and then another one in 2024, one which I just concluded. Contrary to the cliche, don't underestimate the power of one. That first trial I was enrolled in was a phase 3 study. 400 participants spread across 200 sites around the world. I've run the numbers, I've done the math, I consulted AI. It's an average of 2 people per site. And as we heard last night at the industry update as well, a lot of these sites would have had just 1 single participant. Think about that. Your decision to raise your hand and step forward can really make a change on the pathway to progress. Does your physician know you might be interested in participating? 1 or 2 hands can still change. Of course, one of the biggest challenges with PSC research, especially with these trials, is recruiting enough participants. The exclusion criteria are strict. To poach a term from astronomy, there's a small group of us that are in this Goldilocks zone. We're just early enough in the disease to qualify. But even if you don't meet the criteria for these trials, or your hospital might not be a site, there's still many ways you can make a huge difference. Participation comes in many forms: surveys, blood samples, sharing your routine imaging or your clinical history, participating in projects like WIND. This doesn't even have to be just for PSC. It could be for IBD, autoimmune hepatitis, or any one of these other laundry list of conditions we get hit with. Every contribution counts. So if you've ever felt small in the face of this rare disease, remember, you can turn powerlessness into action. Every survey completed, every trial joined, every story shared, these are the moments that can help move the needle and shape a brighter future for PSC. Thank you.
Okay, so it is my honor to introduce the next speaker, who is Dr. Mark Swain. He is a professor of medicine and holds the Cal Wenzel Family Foundation Endowed Chair in Hepatology at the University of Calgary. He is a clinician scientist with long-standing basic science and clinical research interests dedicated to improving our understanding of how immune-mediated liver diseases like PSC lead to the development of symptoms, including fatigue and brain fog. His work has uncovered new understanding of how the liver and brain talk to each other and how this crosstalk can lead to alterations in brain function to cause liver disease-associated symptoms. The goal of his research is to use this better understanding to develop improved treatments and approaches for the symptoms commonly experienced by patients with liver disease and which often adversely affect their quality of life. So Mark, thank you.
Hi, everyone, and thanks very much to the organizers for inviting me to come and speak. It is kind of weird to talk without a podium, I must say. I'm just kind of used to that. I almost feel like I'm on Oprah or something. So my talk is on why does my PSC give me brain fog? These are my disclosures. So first of all, what is brain fog? I think everyone has their own ideas of what brain fog is for them personally, but basically, because it's a symptom or a bunch of symptoms, it's a change in brain function, which people can experience as a wide range of symptoms, and it's often experienced quite differently by different people. And so when you look at brain fog as a group of symptoms, this is just some of them, but often it's difficulty concentrating, it's losing memory or track of memory, mental fatigue, global fatigue, slow thought processes. These are all part of the things that make up brain fog. The problem in the medical literature is that brain fog is viewed very differently, and because of how it's viewed, it's often construed as something that may not even exist. I'm sure you've all heard that from your doctors. Because it can be viewed as a symptom. So for some people, it's just brain fogginess. Or I lose my thought train. For some people, it's a group of symptoms or a syndrome where they have maybe 2 or 3 symptoms that they always have. And for other people, it's kind of non-specific. I just have brain fog, which they can't even necessarily pin down, or multiple things that vary. So when you have these kinds of things that vary between them, it's hard to really pin down and then follow it along and do research on it. And in fact, when you go to open evidence, which is like ChatGPT for doctors, and you just type in cognitive impairment and PSC, this is what you get. cognitive impairment is not a recognized primary clinical manifestation of PSC in the current medical literature, okay? And they talk about other things that are, like fatigue and pruritus, jaundice, abdominal pain. So, however, when you talk to people with PSC and you start to ask them, they often will describe a bunch of different symptoms, things like impaired attention, memory, mental clarity. And often it can be associated with fatigue, and often brain fog and fatigue go hand in hand. I'll talk a little bit about why that is. And anecdotally, it's pretty common in PSC, although the exact number we don't know, and it often significantly impacts people's quality of life. So I want to just bring up Donna Evans' research. It's been mentioned a bunch of times. I think she did a breakout session yesterday, which I didn't get to, but I think she's trying to move the needle on this. And I think this research is very important. It's very important to try to be involved in it if you can. It's a funded project through PSC Partners. And basically, it's really to try to get a handle on these symptoms and the symptom complexes that people with PSC experience, so that when they go to do clinical trials, they can understand it better and follow it. And these are two things that she's going to be presenting at the liver meeting in Washington in November, and one of them specifically on cognition. So why do people with PSC get brain fog? Well, I think most of us, when we think of things like brain function and stuff like that, we think of our brains as a big black box where stuff happens in there and then we behave as we do, right? We don't really understand what's happening in our brain. So I'm not going to turn you into neurosciences, that's not the intent, but I think it's important to understand that in our brain, the different areas of our brains are always talking to each other, always. Even if we're not thinking about anything, they're always talking to each other, okay? And by talking to each other regularly, that's what we call a brain network. So these are parts of the brain that are always talking to each other. And the brain networks, on their own hand, are talking to each other. And so there's this complex intertalk happening just to be sitting there doing nothing, let alone doing something. Now, there was this super cool thing that just came out September 5th, okay? This is from labs all over the world, okay? And this is a mouse brain, all right? All the little dots you see are nerve cells in the brain, okay? The bigger the dot, the more activity that nerve cell is doing. And the colors represent nerves that are part of the same network, okay? So, and this is a mouse, that's actually many, many mice across the world, where they basically, the mouse is trained, so there's a screen, the mouse has a little wheel, it can go turn that wheel to move a little cursor into a circle. If it moves that into a circle, it gets a sugar water reward, okay? So it's all about making decisions to do that to get the reward, okay? And this is what the brain does when all that's happening. So what happens is sort of quiet, sort of sitting there, and then it goes, okay, oh, I see that. So and now look what happens. And this is actually the feedback is the reward, okay? So this is this is a brain sitting there. It sort of goes to the visual cortex, which is seeing. It goes to the motor cortex, which is turning that wheel, and then it gets the reward, and look at that, okay? It reminds me of a kid playing a video game, right? Like, this is the reward. So look at all of those networks that are talking to each other, all right? Just important to remember that picture in your mind. Because if you screw up one of those pathways, you can see how it screws it all up, right? And so if you start to do things that change something in your brain, even if it seems to be relatively mild, it can make a big influence, okay? So what happens in PSC? Okay, so PSC is, as you all know, is very commonly associated with IBD, all right? So I'm going to talk about these sort of together a bit. So people talk about this brain-gut-liver axis, okay? This is what they're talking about, okay? The gut has microbes in it and other things, and they make compounds that are released out into the blood, and they go up to the brain, okay? And this is the whole microbiome thing that people talk about. And when they go to the brain, they signal the brain to change brain function, okay? That's called the gut-brain axis, all right? But when the gut makes stuff, or stuff goes through the gut, or it absorbs stuff, all of that blood goes through the liver. And when it goes through the liver, it talks to the liver. It can be a good talk or a bad talk, but that's the gut-liver axis, okay? That's number 2. But the liver in PSC is inflamed, it has a lot of injury going on, it releases all kinds of stuff in the blood. That stuff leaves the liver and it goes to the brain and signals the brain. And that's called the the liver-brain or brain-liver axis, okay? These things are all happening in people that have PSC and PSC with IBD. It's more complicated than that. I'm not going to get into it, but this is more complicated. But obviously, this is all distills down to those three pathways, okay? So can brain fog be assessed in people that have PSC? Because we have to assess it, because we need to understand it, so we can then see how treatments impact it. And so it's important for everyone to understand when people are talking about this kind of research, they talk about subjective stuff and they talk about objective stuff, all right? Subjective stuff is the stuff that Donna Evans is doing, okay? This is asking people how they feel, and then people say, this is how I feel, this is what I can't do, this is what I can do, okay? That traditionally has not been viewed in the medical literature as being something that people pay attention to. I'm sure you talk to a doctor and you'll start to tell them how you feel and they start to look over, well, your number looks great, right? Because the number is the objective thing, right? So the objective thing are things that you can get published, people report, it's reproducible, they follow the numbers, right? So it's important to understand those differences because it's very different on how people view research, okay? And it's important that we bring those together. So, as I said, Donna Evans' stuff is really about subjective testing. It's asking people in a very formulaic way so we get information back, so we can use that information to understand if, are we doing this thing, is it making them feel better or worse? If we don't really know what the baseline is, it's hard to do anything that's going to be driving a medication or a treatment program. And this is the kind of questionnaires, maybe many of you have filled them out, but basically they're just questionnaires that are really looking at a complaint or an issue or whatever. And this is the cognitive, this is for cognitive function, or cognitive function is basically thinking clearly, okay? And it's produced by this group called Promises NIH. It's been around for a long time. These are well-validated questionnaires. It's important to recognize that brain fog is not dementia, okay? A lot of people say, I think I'm going crazy, I'm demented, I can't think straight, I'm forgetting everything. It is not dementia, all right? So can we also now, so Donna Evans doing this subjective stuff, very, very important. Can we also use objective stuff? Is there stuff that we can do to actually quantify things that are going on? So because sometimes there's discordance between those. Because the objective stuff is stuff that the agencies like the FDA and whatnot, they look at that's the stuff they look at the most rigorously, okay? So if you can generate objective stuff, often you get heard more widely. So there are cognitive tests that you can do. So cognitive tests are actually testing these things, like your memory, your recall, your ability to think quickly. All of those things can be tested with very formalized tests, okay? These are three of them, okay? There's lots of them, but so the one trail making test, you've got these circles with numbers and you say, okay, join with a pencil, join those circles 1, 2, 3, 4, 5, 6, 7, and I'm going to time you, okay? And just do that. And you just have a time, right? The one that's called the Corsi block tapping test is a bunch of blocks sitting on a table, and the person who's examining you taps them in order, and then says, okay, tap those. And they start with just 2, and then go to 3 and 4, and you see how many you can do before you start to make mistakes, and then they'll repeat that, and if it's the same number, that's your number you've got. The digital span test is they'll say, okay, here's 3 numbers, 1, 5, 9, and then you have to repeat them. And then you still repeat them backwards. That's the digit span test forward, digit span test backward. And they just increase the numbers until you can't do it anymore. Very measurable, reproducible. Another way to do it is neuroimaging. This is something that I'm quite interested in. We've been doing in our lab for a long time. So the question that we asked are there objective brain changes? And this is about PSC, because I'm here, but what I've been doing up until recently is PBC and IBD. But can we look in the brain and see, are there changes that happen that we can see on something that we can show people, like the FDA, and say, these are changes, these brains are different. And so we use something, this is an MRI machine. Many of you may have had an MRI. This is no different than a standard MRI machine. You just have someone that knows how to pull different data out of it. And it's called a functional MRI. A standard MRI, I think as you all, many of you had, if you tear your ACL or whatever, they do an MRI and they see that you've torn your ACL, right? It's very good for structural changes, all right? But functional MRI is different. Functional MRI takes the different data out of it, and what it does is it looks in the brain. It can do many things, but it looks in the brain and it says what parts of the brain are active at the same time. So parts of the brain that are active at the same time are felt to be talking to each other because they're active at the exact same time, and they're part of a network. And the closer they are to being activated at the exact same time, that's stronger connectivity. If they kind of are all sort of talking or active at the same time, that's called a weaker connection. And if they're not active at the same time, then there's no connectivity there, all right? And so this talking is linked to our behaviors and what we do and our thinking and our clarity of our thought, all that stuff. I'm going to talk just about 2 parts of the brain. That's it, okay? So the 2 parts I'm going to talk about is the amygdala. So when people are talking about the emotional brain, they're talking about the amygdala. That's the part of our brain that really regulates our emotion and puts everything we do in our lives in the context of emotion, all right? Our memories, our interactions with people, everything. The cortex, it takes all of the stuff that comes from all of our senses, our bodies, everything, takes it in, and it does all of this high processing. So it basically, it does memory, thinking, learning, reasoning. It does, like when that mouse brain, when the mouse saw the thing and the part of the brain that looks at processes visual stuff, it went to the other part of the cortex, and all that was being processed into that mouse turning that wheel. And when that mouse got that wheel thing in the middle, it was a pretty happy mouse, and the reward system kicked in. So when you look in PBC patients, and I want to look in PSC patients, and you look at how these 2 parts of the brain talk, well, they talk differently, and they talk differently reproducibly in PBC patients, and it correlates with a decreased performance in that digit span test, remembering the numbers. So it actually changes in their brain talking that you picked up on the MRI correlates with a not being able to do that digit span test as well. And you can do this with fatigue and itch and all the other symptoms, cognition. And so as it was mentioned earlier, so we were very fortunate to get a PSC Partners seed grant, and we were just funded. And now it's going through our ethics in our university. Hopefully it'll be ready to go very shortly. And we want to do this in PSC. So it's basically large duct PSC, with and without IBD, and we're going to do the subjective testing, so questionnaires about fatigue, cognitive impairment, quality of life. We're going to do objective testing, so those tapping the tests and do the digit span tests. We're going to take blood samples and poop samples. So the poop samples are to look at the microbiome and see what's happening there and what it's making. So that's how it makes stuff to signal the brain. And we're going to take the blood samples to look for the things that come out of the gut or out of the liver that can signal the brain, and mainly cytokines are called. And then we're going to do that special MRI testing to see if we can see these objective changes on how the brain's talking to each other. And so this is kind of the summary. So basically we're going to look at the gut-brain axis, we're going to look at the liver-brain axis, and then we're going to see how the brain is changed. I got 1 minute left, which is perfect, actually. So I'm just going to finish off here by by saying, so why do fatigue and brain fog go together? Okay, because people sometimes say that the same symptom, there's different symptoms. Some people have fatigue, some people have issues with brain fog but don't have fatigue. So look, why does it some people have it affect them together and not? Well, so when you look at the brain, and you look at the brain networks or systems that regulate cognition, so that's brain fog, and you look at the brain systems that regulate motivation, and fatigue is really a balance between motivation and reward, just like that mouse, motivation and reward. Everything we do in life, even if we're not thinking about it, is based on motivation and reward. Our motivation to do something to get a reward that we might not even appreciate. right? That's what it's all about. But you can see these are overlapping. If you screw up one of those systems, you're very likely going to impact part of that other system, and this is why they have a tendency to go together. So I'm going to summarize by saying that understanding the range of symptoms experienced by people with PSC and defining objective brain changes associated with those symptoms is not just important, it's actually critical. It's critical because it empowers PSC patients, to understand the symptoms. Their symptoms come from real changes in their brain. And these need to be addressed if they have any hope of achieving holistic wellness, because we see a lot of treatments that we have treat the diseases, they don't impact the symptoms. So we need to view these things as they need to be both addressed equally, and they're now being more included in studies. And I'm just going to finish off by saying it's so important to have both subjective and objective approaches as we study people with PSC. So the Donna Evans stuff and what your Alk Foss doing, really important to put together. Because we have to define this change in symptoms that occur or don't occur with the treatments that are targeted at the liver disease itself. Because if you make someone's liver feel better and you're making them live longer, but they feel like crap, is that really extending their life, right? You're creating a long life story of someone who feels unwell. So you need to deal with both of these things, not just one. And so it also gives you a capacity, when you understand these things better, to develop treatments that are actually they're targeted towards the symptoms, not necessarily the liver disease itself. Obviously, the perfect treatment does both. But if you have a treatment that affects the liver disease and improves it, but it doesn't improve the symptoms, you really want to have something that's going to improve the symptoms too. So this gives you that opportunity. Thanks very much.
Okay, so our third speaker is also from Canada. So way to go, PSC Canada. This is Sarah Ahola Kohut. She is a clinical and health psychologist based in Toronto. She is a staff psychologist of the Hospital for Sick Children, a researcher with the Sick Kids Research Institute, and an assistant professor with the University of Toronto. Dr. Sarah Kohut's program of research focuses on resilience and mindfulness to support values-based living in people with chronic disease. Clinically, her experience includes over 10 years at the IBD Center, also serving young people with PSC. Dr. Sarah also has a private practice where she focuses on seeing adults with chronic disease. So thank you.
Thank you. I 100% agree. It's so bizarre not to have a podium here. Thank you, everyone, for being here. I always find this community so inspiring for so many reasons, and it's because you show up, and you show up with your full hearts. I actually want to take some time today to talk a little bit about grief. I think this is something that is often really ignored in society, and I think people are really afraid to talk about it. So I want to go a little bit through the who, what, where, when, how of it. And ultimately, all of us at some point are going to experience grief. And I think it's really important when you're living with PSC or you get to love someone with PSC, because some of those symptoms really overlap. And I don't think you always realize that part of this is grief and that is 100% normal. I think even if you are someone who's asymptomatic, you have lost the rose-colored glasses because you know that sometimes bad things happen. Maybe it's about losing what you thought your life might look like. And certainly there are instances where it is actually really traumatic and it's about traumatic loss or really complicated grief. So again, why am I bringing this up? And I think because in society, grief is always associated with death, but it's really about loss. And this is a natural, as I said, part of life. And I think if you can acknowledge these feelings and integrate them, it allows you to better choose how do you want to show up? How do you want to control the controllables? And how can you allow yourself that space to grieve without guilt? Feelings that are acknowledged in a safe environment often settle a bit on their own. It's not about fixing them. It's about acknowledging them. And this isn't a doom and gloom talk, because I think the part of grief that's so beautiful is it just really highlights with crystal clarity what really matters to us and who matters to us and how do we want to live life. So when we think about grief, I really kind of want to bucket kind of 3 sections where we think about sadness, we think about grief, and then certainly as a psychologist, sometimes it is about clinical levels of depression. And I want to highlight the piece that is so complicated and confusing and makes this messy is that fatigue and brain fog are common across all 3, right? And what I want to highlight, I'm going to focus more on grief because grief really is a process. Sadness is an emotion, it's often temporary, it resolves on its own and doesn't impact function. On the other end, depression is a mental health disorder that requires treatment, often multidisciplinary treatment. Grief is a process. It's not something to get over. It's something that you learn to walk with, and it might impact everyday life. Some folks do really well with just connecting with other people, while others require some type of treatment or therapy. And there certainly are physical symptoms associated with grief. I want to highlight too that grief can come out as anger, resentment, pessimism. It's not always just about that deep sense of loss. So if there are times that you're feeling really angry, or you're longing, or you're snappy, you may want to pause and just consider, what if it's actually about grief? There's also something called ambiguous loss, and that's when the grief is really unclear. There's no end, it's incomplete. And this is what is often really, really not acknowledged at all in society. And this might be grieving all the different versions of your life that you're not going to lead. And yes, this is something that happens in PSC. It also happens to many of us. I didn't live the life where I got to live in a van and travel across North America. And I don't say that to make light of it. I share that so that you realize it's a natural human experience. I think ambiguous loss in particular can make us feel really stuck. And I think we get stuck in it because we're not naming it and we're not recognizing it. So that's where, again, you get that disconnection, that stuckness, anger. Sometimes it's just that stress. So it's an invitation to ask yourself, if my struggles were about grief, how might I treat myself differently? Might I give myself a little more grace? Now here's the thing, in PSC, energy and fatigue is wildly important. And often I hear in my clinical practice a lot of the I should have done this, or not giving credit when you do things that, I don't know, other people just seem to do it easily, so I shouldn't give myself credit for doing those things. But you should. You're doing it in hard mode. So often I find folks living with PSC you don't give yourselves enough credit for the work that you're putting into it. I really love this quote, and I wish I could associate it with a person. You are not a burden. You have a burden, and which by definition is too heavy to carry on your own. And asking for help and getting help from others is giving them an opportunity to love you. Being able to show up for people that I love is a get to do, not a have to do. And I think following a PSC diagnosis, even if asymptomatic, really sometimes that loss is about a change in your ability. Maybe you were an athlete that had to give it up, or a job you had to give it up. Maybe it's the uncertainty. Our brains hate uncertainty. We'd love to know what's going to happen. Sometimes it's grief around disease progression. And these are very normal, natural things that anyone in your position would be thinking about and feeling. So thinking about the when are potential moments where grief might bubble up? And in my experience, there's lots of different moments, right? It may be at diagnosis. Maybe it's a first flare after a period of wellness or a change in treatment. I also find that there's this kind of period of time around 15 to 18 months after diagnosis where suddenly things sort of become more normal and people aren't showing up in the same way for you. It becomes kind of old news. And that's when you really settle into the fact that this is a chronic disease. I also find important dates. Maybe it's an anniversary of a diagnosis or a transplant, or maybe it's a major life event, a graduation, a wedding, a birth. And then also, it can be absolutely random and you can feel like you're playing a game of dodgeball you didn't know you were playing and you just got whacked in the face while you were walking down the street. I think grief has this way of just coming up when you smell something, you hear something, a song. And the invitation in these moments isn't to try to fix it, it's just to acknowledge that it might be grief. And that it's hard because it's hard. Not because you did anything wrong. So how might you care for yourself in those moments where it bubbles up? I want to leave everyone with just a bit of a choose your own adventure of different things that you can do to help walk alongside grief if that is your reality in this moment. Certainly movement. I'm sure you've heard bodies in motion, stay in motion. Depression hates a moving target. I also know that energy is a finite, a limited resource for many of you. So this isn't a matter of go get yourself moving for the sake of moving. It's moving because it matters. So really pacing your day and prioritizing what and who is important to you. I also want to implore everyone to please schedule time to do nothing, where the only question you ask yourself is, have I been lazy enough? We will schedule our lives, and whatever time is left over is the time to rest. Let's be radical and just schedule the time to do nothing. I also want to think about this from the perspective of the mind. And there are a lot of things that we can't control, and we will grasp at control as much as we can. Let's focus on controlling the controllables. What has not been canceled, what has not changed, right? And if you're going to consider the worst case scenario, let's be absolutely just unhinged about thinking about what the best case scenario is. And that's not because I necessarily believe the best case scenario is going to happen or the worst case. It's so that you recognize what the range of possibility is. We live so far and so close to the negative and what could go wrong. It's an invitation to really recognize the range. I also, working with young people, I will often tell them, because they're saying, oh, well, I should be doing this, I should be working full time and also going to school and doing, and I often tell them, I'm like, you need to stop shoulding all over yourself. And if you notice that you have a should coming up, I want you to ask yourself genuinely, do I have to do this? Do I want to do it? And if you don't have to and you don't want to, just reconsider that should. You are allowed creating your life the way that you want it to be. That's one of the beautiful things nowadays. Even working 9 to 5, Monday to Friday isn't as common anymore. Let's just get creative. I wouldn't be a psychologist if I didn't talk about feelings. I do like talking about them. I also enjoy helping people feel them. I am a big fan of saying hello to feelings and just acknowledging them. And as ridiculous as it sounds, I will do that. I will say hello to my anxiety now because I am speaking with a microphone. Somehow in a breakout room, I'm totally fine. Give me a microphone. Hello, anxiety, because I'm convinced I'm going to say something absolutely ridiculous. I also want to remind everyone that feelings and emotions are sensations. We don't always have to find words for them. Labeling feelings can be really helpful. It's also okay to just notice, oh, that's heaviness, or that's buzzing, or that's pressure. Where is it in your body? Maybe even asking yourself how old the feeling is. And you can use words that are associated with sensations and intensities. It doesn't always have to be words. For those in the audience who find feelings really difficult, honestly, if you are someone who is in a place where maybe there's grief or maybe there's sadness, put on a really sad movie or a psychological thriller and allow yourself to really feel the feelings. So much of it, when they say processing feelings or working through feelings, it's not about thinking and labeling, it's just having the experience. Have the ugly cry if you need to have the ugly cry. And for some, I do think it's easier to do if it's associated with a movie or a song or anything that can help you get there. As I said at the beginning of my talk, I really do love this community because you show up for each other. And just am so inspired often about when the community comes together, the feeling of it. So you're already doing a lot of the things that I would recommend to folks when they get diagnosed with a chronic disease. Find your people, right? There are going to be people who don't show up for you, and that's okay. They can go find less. You can find your people, and please think about boundaries and setting aside time for rest. And I'm someone who works with folks who have Crohn's colitis and also PSC. And whether we're talking in the GI space or in the feeling space, I always say it's better out than in. Just share it with the people who matter to you. And again, I want to end with that, I couldn't say this too many times. It's hard because it's hard. This isn't hard because you did something wrong. It's just hard. And you're not alone. We have a whole room full of folks here and countless others across North America and the world. So the invitation is, what can you do to care for yourself because it's hard? Not necessarily to fix or get rid of hard, but just how do you care for yourself? Because you might be grieving, and it might just be hard. And with that, I will end and say thank you for the time and energy and everyone showing up today.
We're changing gears a little bit. My pleasure to introduce Dr. Steve Rossi. He is the Chief Scientific Officer here at PSC Partners. And prior to that, he has spent the last 30 years working in clinical research, developing new drugs to treat a variety of liver diseases, including PSC. He is passionate about collaborating to bring the patient voice into PSC research. So thanks, Steve.
And I didn't need the introduction twice, but I'll take it. I'm really up here this time to introduce something again that we briefly touched on, which is how is your voice helping to move the needle? And we mentioned, and you've heard, that cholangiocarcinoma is something that is just out there facing all of us. It is causing fear, anxiety, and even in all of the areas that are prioritized for research, understanding and detecting cholangiocarcinoma constantly rises to the top. As I mentioned, we did a survey and we found out that patients aren't being talked to about it, that they are often, if they are talked to, they're often left with a feeling that there's nothing that can be done. And so really we've taken this on not only from an education perspective, but from a research perspective to try and really help move the needle. And as I mentioned, at our ICRN this year, we got 7 top-notch proposals from the community and from the researchers. And it was clear when we put it out to all of you what was the one you wanted us to fund. It was around early detection of cholangiocarcinoma. And so today, I'm actually, instead of leaving with the message that, what do we do? Nothing can be done. We really are about to see 2 speakers who can actually say we are starting to move the needle. Dr. Pedro Rodriguez is here from San Sebastian, who is the lead scientist at the university there, discovering and working on new tests for both the diagnosis of PSC, but also for looking at early detection with a blood test. And so that's really something that could change the game for us. And partnering with him is Dr. Juan Valle, who is an oncologist, formerly in the UK, working in trials, treating patients, actively involved in biliary tract cancer therapies, and made the jump to join the Cholangiocarcinoma Foundation, one of our partnering groups that we really plan to help move, again, the needle forward. So I'd like to bring first up Pedro to speak to us on early detection.
About to explain a little bit about what we're planning to do with the Biomap PSC project, aimed to conduct practical validation of new tests for PSC and PSC cholangiocarcinoma, and try to prepare this proposal. We were asked to answer 4 questions. So why, what, who, and how? So I will go through each one of them and try to explain what are our aims and what are we planning to do with the tests. So starting with the how, with the what, sorry. So basically, we aim to find novel liquid biopsy biomarkers, so new tests that could be used to the early detection and to estimate the risk of cholangiocarcinoma development, specifically in patients with primary sclerosing cholangitis. And to do so, we aim to standardize and unify the protocols that could be done in the future to maximize the utility of liquid biopsy tests and biomarkers that will be used to validate and correlate with clinical, radiological, and even histological data, and also harmonize the protocols for sample collections within clinical trials, within patients that want to participate in different studies. And by doing this, we want to collaborate with different perspectives, longitudinal cohorts, by generating some data and using some of the samples, and for example, using some cohorts in Europe, such as the FICUS cohort, the Supreme cohort, the cohort of Norway, UK PSC, and collaborate with the International PSC Study Group, but also cohorts from USA and Canada, such as the WIN PSC trial, the children cohort, even the ICRN US, or cohorts from the Mayo Clinics. So what have we been doing so far? So we have been deeply interested in trying to find the test that allows not only the diagnosis of PSC, but also the early diagnosis of cholangiocarcinoma in patients with PSC. So we have been interested in studying very small molecules in blood that are called metabolites. Metabolites are secreted by all the cells and are able to be detected in all biological fluids. So what we have done, we evaluated the whole metabolites in the serum of patients with PSC to develop these tests. And to do so, we collaborated with 13 healthcare centers for 8 worldwide countries and counted with the collaboration of several international collaborators that are key experts in PSC. And of course, this would not be possible if it was being funded by PSC partners and PSC supports and by different international associations. So basically, with this study, we enrolled 470 patients, and after applying the exclusion criteria in which we excluded patients with other extrahepatic tumors, patients with had HBV or HCV infection, with patients with concomitant autoimmune hepatitis, or from who missing important information was missing, we were able to include 434 patients in the study that were divided according to the aims of the study, either to develop a test for the diagnosis of PSC or a test for the early diagnosis of cholangiocarcinoma. And in this case, for the PSC test, we included patients with ulcerative colitis, patients with isolated PSC, and healthy individuals. And for the cholangiocarcinoma test, we included patients with PSC that we know that did not develop any tumor in more than 5 years of follow-up, patients with PSC and cholangiocarcinoma at sampling, and patients with PSC that we know that developed cholangiocarcinoma during the follow-up, but when we obtained the sample, there were no clinical evidence of the tumor. And we call these patients PSC2-CCA group. We developed, divided the patients in discovery and validation cohorts following a proportion of 60% and 40%. So regarding the first aim, which is the test for the diagnosis of PSC, so after measuring all the metabolites in the serum of patients, we identified almost 500 metabolites and then selected the ones that allow to differentiate patients with PSC from healthy individuals. Since we want a robust test that would allow to diagnose PSC independently on the presence of ulcerative colitis, we then excluded the metabolites that allowed to distinguish patients with ulcerative colitis and healthy individuals. And moreover, we also excluded the metabolites that were associated with the biological sex of the patients, that were associated with their age, and with the presence of liver cirrhosis. So we were able to identify 50 candidate metabolites that could allow to distinguish PSC from healthy individuals independently of the biological sex, the age of the patients, the presence of liver cirrhosis, and the presence of ulcerative colitis. We then ranked these metabolites according to their importance for PSC diagnosis and selected the 13 first metabolites to generate a new test for the early diagnosis of PSC, which, as you can see here, achieved an area under the curve zero of 0.98 in both discovery and validation cohorts. And as expected, this test did not allow to differentiate patients with ulcerative colitis from healthy individuals. To confirm this, we observed that this test really worked for the distinguishing of patients with PSC, specifically with ulcerative colitis, compared to patients with ulcerative colitis, and also patients without any type of IBD compared to healthy individuals. We also confirmed that this test works for the identification of patients with PSC and Crohn's disease, and also for patients with PSC without any type of, with an unspecified type of IBD. So as for the early diagnosis of cholangiocarcinoma, we follow the same strategy. So we detected the metabolites, we selected the ones that allowed the diagnosis of cholangiocarcinoma in patients with PSC, and then we specifically selected the ones that allowed the early diagnosis of cholangiocarcinoma. And then we excluded the ones associated with biological sex, with the age, with the presence of liver cirrhosis, and also with the anatomical subtype of cholangiocarcinoma. We followed the same strategy. We ranked the metabolites according to their importance, selected the first 30 metabolites to generate the new test, and evaluated their performance. As you can see here, this test allowed to differentiate patients with PSC and cholangiocarcinoma from patients with isolated PSC with an area under the curve value of 0.91 and 89 in discovery and validation cohorts, being superior to the current gold standard CA99, which is currently used in clinics. And this test retained its diagnostic capacity when patients with early tumor stages were selected. And most importantly, when we selected patients that had a false negative test result for cholangiocarcinoma, I mean with low levels of CA99, the test provided an area under curve value of 0.92 for the detection of cholangiocarcinoma. So if we go to the group of patients that developed cholangiocarcinoma during follow-up and stratify them according to the time between sampling and cholangiocarcinoma diagnosis, this test performed really good if we include patients with less than 1 year and more than 1 year between sampling and cholangiocarcinoma diagnosis, being superior to CA99. So why is this important? Because there are important urgent needs in patients. We need to estimate the risk of cholangiocarcinoma development in PSC, and also to distinguish benign and malignant strictures in these patients. And this may benefit all the patients because we may allow to early detect these tumors and intervene as soon as possible. And you can also maximize the value of all the samples and also be a significant benefit for patients with pediatric PSC as well. This may have a huge impact in the patients. There's a huge technological innovation in this test, and it has short to mid-term and long-term impacts. But as a summary, it may impact on patients because we can early detect the tumor and intervene as soon as possible to try to cure this tumor. So we will map distinct prospective PSC cohorts, establish standards protocols, generate a virtual and a central biobanking for samples, and we will try to develop and to establish the roadmap that we need to follow now to translate these tests into clinics by engaging also with regulatory and industry experts and to apply for other grants to secure funding. We will collaborate with key stakeholders and collaborators within Europe and USA, and we will with companies and biotech companies that might be interested in this test. And last but not the least, patient advocacy and support organizers will be pivotal in this study, including PSC partners, but PSC supports from UK, the Cholangiocarcinoma Foundation in the US, AMMF in the UK, and also ICRN, where I live. We will involve all patients in this process by making a global patient involvement, increasing awareness and education, and providing a knowledge transfer of our results in a lay language. And all patients will be involved in all the full levels of the study. And with this, I would like to thank our research group in San Sebastian, and most importantly, the PSC partners and PSC support associations and all the patients that have been working with us, and without them, we will not be able to do our work. And thank you very much for your attention.
Thank you very much, Steve, for the kind introduction. It is a privilege to be here. I kind of feel a little bit like the unwanted uncle that turns up at a barbecue to talk about cholangiocarcinoma in this setting. But I hope that by the end of my presentation, you will see that we also are full of hope, particularly focused around the research. So let me tell you a little bit about the foundation. Our mission is to find a cure and improve the quality of life for patients with cholangiocarcinoma. You can see here our vision is a world free of cholangiocarcinoma, and we have 4 core values: patients first, and that is probably the most important one for us; innovation, which then speaks to the research that we do; collaboration, and it's with that in mind that we are here, and we have in fact been working across the 2 organizations more closely together over the past year to 18 months. But also a sense of urgency. Patients need new treatments, and they need them now. And so we want to make sure that we make that progress as quickly as we can. So the community, similar to yours, involves patients, caregivers. We have medical professionals as well as scientists. We work very closely with industry, volunteers, as well as regulatory agencies and donors. I'm not going to go through this in a lot of detail. I just want you to take one key message here, is that we have 2 strategic pillars. One is very much about supporting patients and caregivers, and the second one is around research and breakthroughs. And it's really on the latter that I came across as a clinical academic from the UK 2 years to join the foundation to really help with that research program. And I'll go through some of the things that we do in the next few slides. We also have an annual conference, and at our annual conference this year, these are just the numbers summarizing some of the things of the conference, but I just want you to focus on the middle at the bottom. We held a consensus conference of research priorities. So we divided the field of cholangiocarcinoma into 10 working groups. Those working groups then did some work ahead of the conference, looking at deep dive into the literature. What are the research priorities for my working group, whether it's surgery, local regional therapies, systemic therapies, and so on? Where are the gaps? so that we can then prioritize and align the global community in terms of the research that's taking part, not just here in the US, but internationally. So we identified 52 research recommendations that were brought forward, and we're now working those, and in fact, one of those has been funded as one of our innovation grants, and I'll tell you more about that in a second. In terms of patients and caregivers, we have a newly connected program. So for patients who are newly diagnosed or newly aware of the foundation, then we provide a care kit. We want to provide them with a specialist map. We know it's important for cholangiocarcinoma to be treated in centers where they know about the disease. So we use that specialist map to make sure that patients are connected with a specialist team, and there is access to a lot of educational information. We have a number of support groups, as you can see here on the list. Some general ones, some are for young adults, one in Spanish, and so on. We have patient education webinars, and these are very hotly taken up either on the day of the webinar itself. All of these are posted on our YouTube channel, and very often you can see that people will follow up afterwards and have a look at these on YouTube, depending on what the topic is that they want to focus on. We have a volunteer program, and you can see the volunteers here are supporting the annual conference and a whole list of other activities, so patients can get involved as well as their loved ones. We also have a mentoring program, so that we match people very close to somebody in a similar situation to where they are, and very often mentees then graduate to become mentors of other new patients who are subsequently diagnosed. And we also have a group of research advocates who, as you heard from some of the sessions earlier, are involved in the development of research right from the start, not just coming in at the end, reading the patient information sheet and signing that off. It's really about making sure that patients are engaged in the research all the way through. And we have care teams which are more local setting. You can see in the various locations here where they're able to get together and have support and education within their own communities. And very often we try and link those with the local clinical teams as well. And we take our annual conference on the road, and we have regional symposiums. And the next one, as you can see, is in Chicago at the end of the month. And we're gradually getting these expanded year on year. And we want to make sure that we are reaching every patient everywhere by ensuring that we have appropriate translations of some of our materials. This is an example of a nutrition book, for example, that's translated into Spanish as well as Mandarin. And you can see a number of other activities there. In terms of the research, we're supported by a scientific and medical advisory board. These are the who's who of key opinion leaders in cholangiocarcinoma, as well as a nursing advisory board, which has now expanded to be nurses and allied healthcare professionals, including social workers and physical therapists, for example. We also have an ICRN, but it stands for something else. This is our research network, and this is exemplified by the fact that we work with people like Pedro and his team through the ICRN, this international community trying to move the needle in cholangiocarcinoma. We have 4 different committees: a program organizing committee, a next generation committee, data committee, but our heart is really in the research. We have funded 71 research fellowships since 2015. And in addition to the fellowship program, which is very much our early career, we have a mid-career career development award and also senior grant awards, which are the innovation grants. We've just started now through the process of awarding our second innovation grant. So we want to make sure that we're supporting people all the way through the research portfolio, and very happy to talk about all of that going forward. We're just about to celebrate our 20th anniversary. Our next conference is in Salt Lake City in next year. I know that nobody wants to get cholangiocarcinoma, and most patients won't. But if you do, there is a community there for you. We have that strength in that community and hope in the research going forward. And over the past 15 years, particularly over the last 5 years, we have seen huge advances in new therapies, particularly understanding the biology of cholangiocarcinoma much better and having a number of targeted therapies for very specific molecular alterations within the cholangiocarcinoma. And with that, I'll come to an end. Thank you so much.
If there's any questions, just pass them, and I'll be happy to ask. But maybe I can start with you, Mark. What advice do you give to patients who are having a lot of fatigue and brain fog when they start talking to their physician, who again might just want to be looking at what their bilirubin and their alk-phos is, as well as how would someone with these symptoms kind of approach their job or their school? Because these are things that people complain about the most, but yet we can't really objectify to give advice. And should they have disability? Should they take work off? I mean, just loaded question, but.
That's a very long question, actually. The answer could be very long, but so I'm doing a breakout session this afternoon, so I'll try to save some of the fatigue stuff for that, but because I can't possibly answer all that question without taking up all the time. But I think it's very important so when people do look into these symptoms like brain fog or fatigue or whatever, and you look at what people answer on a questionnaire or what their doctors think they have, are night and day different, right? Because people are very uncomfortable talking to their doctors about symptoms, but they're very open to talking about in a questionnaire, right? And so I think this disconnect has to be brought closer together, and the only way to do it is to be a self-advocate, right? And you have to advocate. Doctors are busy, and they have a tendency to focus on the things that they find comfortable, and they find things that comfortable are numbers, right? That's what is the most comfortable to most doctors, and so it's very important to let the doctor know that how you feel, and to encourage them to quantify it in a way. Like I always say that if you don't quantify, whether it's fatigue or brain fog or whatever, I mean, fatigue is probably the one that's I think people are more inclined to ask about or talk about. Then you can't follow it. You can't. Does that keep checking out on you, or is that just me who's hearing it? Well, it doesn't matter. Maybe I've got brain fog. So I think it's very important for people to advocate for themselves, make sure that the doctors quantify it, make sure that they understand how you're feeling and how you're changing feeling, especially if you're given any kind of treatment or any kind of intervention. They need to know if you're getting better, basically. I could get into management, but that's a long answer. I might not do that. I could come back to that. How's that? Okay. Yeah.
And then how is brain fog different from hepatic encephalopathy?
Yeah, well, so hepatic encephalopathy only happens if people have cirrhosis, right? So if you don't have cirrhosis, you don't have hepatic encephalopathy, and don't let doctors tell you that you do. So when actually I'm speaking in October about is it a continuum? Are people actually, as people get liver disease, and a lot of the signals are going to be similar, right? Is it just a continuum that people get these impairments and these symptoms that as they get to a certain point, then they have cirrhosis, and they get the added kind of burden of having certain things that the liver extracts to prevent hepatic encephalopathy that come from the gut, really, the gut bugs. When you have that added burden on the brain, then you really tip over. And I think there's very good evidence that the brain is changed quite early on, way before cirrhosis happens. And so I think the more we understand the brain changes that happen as a spectrum, because physicians for years looked at the brain changes that happen with hepatic encephalopathy. So physicians are comfortable with that. Again, that's objective. They've got cirrhosis, they've got treatment programs for those symptoms. So it's easier for a physician to talk about that and deal with that. Whereas once the other stuff, it's not so easy to talk about it. And the treatments are less regimented, less protocolized. So, you know, I think it's not important not to be compartmentalized as hepatic encephalopathy if you're not, right? But if you do have cirrhosis and you are having these issues, then to be treated for that is totally reasonable. If you don't get better, that means it's probably not hepatic encephalopathy, right?
And Sarah, you gave an excellent talk, primarily directed at what the patient can do themselves to help with issues of fatigue and loss and grief. But any advice that you can give to the caregivers of these people?
Okay, so if I have to try to think about how to answer this in few words, I would say stop trying to fix everything, I think is maybe the way that if I would say one thing, because I think often as caregivers, we just want to get in there and make it better. And sometimes I think the most important thing is to allow space for the struggle and for people to share what they're going through and just acknowledge it without having to fix it. As I mentioned, feelings and experiences that can be acknowledged in a safe, loving relationship often settle a bit on their own. And sometimes I think it's just about being able to share it and acknowledge it without fixing it.
And then any advice you could give someone that has PSC or ulcerative colitis that lives alone in terms of how they would approach finding a support system?
I mean, I think that's just online, trying to reach out in whatever way you can, whether it's online peer support groups or getting in touch with PSC partners and asking them what's available. And then also asking more locally with the medical team you're associated with, whether it's the physician, the nurse, if there is a social worker, kind of asking what's out there and really taking advantage of online, I think would be the best way to do it.
Then just another shout out to PSC Partners Seeking for Cure. That's probably the best you can have to link up with other people on the net. So lots of questions about the cholangiocarcinoma. How can a PSC patient get one of these blood tests?
Oh. That's a $1 million question now. We are still optimizing the thing, so we are fine-tuning the test. So we did this first study in which we did a discovery and validation with this international cohort. We are pretty confident on the robustness of the data, but we are still validating the data. So now the next phase, conduct a new validation with a new cohort, and we are planning to do it blindly. So we have the samples without knowing which group they are, and evaluate the test in that samples and see blindly if we can allocate the samples into the study groups. And afterwards, ideally, it would be great to then do a prospective validation, so enroll patients and have the samples at diagnosis and then follow them and do a routine screening at 6 months, 1 year, to try to evaluate when and until when can we detect cholangiocarcinoma. Afterwards, if everything goes properly, we believe that will be different central labs in Europe, in USA, that would be doing these tests and providing all the results for all the patients, hopefully as soon as possible.
And it appears that most of the metabolites identified as markers for cholangio are lipids. So does this suggest a specific metabolic pathway that's involved going from PSC to cholangio? Yeah,
that's a good question. We believe so, and actually we did another study several years ago. It was not on cholangio in a PSC background, it was in cholangio in general without any specific etiology. And we actually showed that these cells are highly dependent on lipids to proliferate, and actually the tumors that are more aggressive and do metastasize and do tumors that are bigger are the ones that uptake more lipids and use more lipids to grow. So we believe somehow lipids and these metabolites may have a central role in not only in PSC but also in the progression to cholangio, and that's our next step. So now we want to, with these results, go a step back to animals and to cells and try to evaluate if we can find this same profile in animals and try to find if we can target these lipids to treat and develop novel treatments for the patients.
Question about the nutrition guide. Is there a specific diet that you should be using to prevent cholangio? Is this book only for people that have been diagnosed with cholangio, or should everyone be on this diet now that has PSC?
Yeah, so thanks for that question. With cholangiocarcinoma, there are different nutritional problems arising, sometimes due to the location of the disease, sometimes due to prior surgery. So what the book is trying to do is to give some advice on how to manage those specific situations. So for example, if somebody has a cholangiocarcinoma very low down in the bile duct and they've needed to have a surgical procedure called a Whipple procedure, then they're not able to absorb fats so well. They may lose certain vitamins, and so it's a way of being able to give very informed information around how to manage that, how to manage the diet, how to make sure there's enough pancreatic enzyme replacement, for example. That's just a very specific example. It's not a book that's aimed at the prevention of cholangiocarcinoma. It's really for supporting patients once they've had a diagnosis of cholangiocarcinoma and then maybe have gone on to have certain specific treatments.
Is cholangiocarcinoma less likely the longer you go from initial PSC diagnosis? It seems like if you get cholangio, it happens soon after PSC diagnosis. And if you could also just comment on the collaboration between oncology and hepatology and transplant. For a long time, we were in kind of our two different silos, and oncologists were managing cholangio very different than hepatologists. And if you can comment on that collaboration as well.
Yeah, so I'll maybe start with the second one. You're right. For so long, largely it's been under the remit of hepatology, maybe under gastroenterology, and then oncology, with not very much communication across the different specialties. So one of the things that we have done through our initiatives is to make sure that we bring all of those people together. Now, one of the things that we've also come to realize more recently is that there are many meetings around the world, many academic meetings targeting the liver, but often these are focused on hepatocellular carcinoma rather than cholangiocarcinoma. So we have been working with the leadership of some of the main liver meetings, like ILCA, like EASL, ASLD, a number of other different alphabet soups of different meetings, just to make sure that if there is a meeting around liver cancer, we're also talking about cholangiocarcinoma. We're not just talking about the hepatocellular carcinoma, which arises from the hepatocytes themselves, the liver cells themselves. I'm sorry, the first part of the question, remind me.
Just the timing of it. Is it more likely
The timing,
to
yeah,
be
thank you.
diagnosed early?
Thank you. You saw on one of the graphs earlier that different people either progress with PSC at different times. You can be stable for a very long period of time. There's a lot of variability in how PSC behaves. Similarly, there's a lot of variability in terms of how cholangiocarcinoma develops. In general, we know that cholangiocarcinoma tends to arise in a period of prolonged inflammation. And we know this not just from PSC, we know this from the Mekong Delta, Northeast Thailand, Laos, Vietnam. They have a completely different type of cholangiocarcinoma where, due to something they eat, the liver is infected by something called a liver fluke. And that liver fluke lives within the bile ducts of the liver, and if it's there for 20, 30 years, then the cholangiocarcinoma develops. So that's, again, a reflection of the fact that it's that long-term chronic inflammation that then triggers the development of a cancer.
And this is a question I get a lot as a hepatologist. Cholangiocarcinoma obviously is one of the things that patients are the most scared about. And a lot of times patients will approach me about timing of transplant, even if they don't have cholangio, but should we just be transplanting earlier and earlier to prevent the potential of the development of cholangio? I don't know if you what you think of that approach or how we can reassure our patients.
Yeah, so I think the issue around transplantation for cholangiocarcinoma is an evolving story at the moment. It has previously not been used very widely, and there are now a number of centers that are using it more and more frequently. There is, of course, a sweet spot because if cholangiocarcinoma has become very advanced, particularly with disease outside of the liver, then having a transplantation is not going to give a good outcome and may limit some of the treatments that you can then give downstream. So this is an active area of investigation. There are a number of transplant centers. The criteria for inclusion in the various centers varies. And so that's part of the work that our advocacy team do, is to have conversations with patients around what advice they've been given and whether they do need a second opinion to have that discussion in another center.
Just, I think relating also to that and then bringing in the early diagnostic test, I think one of the roles we should be thinking about as we get there is, we have the MELD exception for HCC. Does this open up an opportunity for, if there's an early detection, that we can see sort of a CCA exception to start bumping PSC patients up similarly, because the outcomes are going to be so much better if it can be, and again, finding that sweet spot. But these are the types of things I think we have to be thinking about, how these tests might actually impact even transplant.
Yeah. I agree. Shifting gears back to brain fog and fatigue, do the symptoms correlate at all with stage of PSC?
Yeah, so classically these symptoms do not correlate with serum biochemistries for sure, but obviously as you get more advanced, and if you get advanced cirrhosis, then you can get symptoms from that, so there can be overlap. There is some evidence that if you have an episode of cholangitis and you get, obviously you feel unwell and you get tiredness and you recover, there is some evidence that you might not actually recover quite to baseline from a fatigue point of view, and so every time you have one of those episodes, you come down to a baseline that's a little higher. But that's in its infancy, I think, but broadly, the symptoms don't correlate. Like in most inflammatory diseases, they don't correlate well with the markers that we typically follow to decide about disease stages.
And Mark, do you know if anyone is looking at vagus nerve stimulation to manage these symptoms?
Leading with?
Vagus nerve stimulation.
I don't personally know of anyone doing that, but yeah, so I really can't comment on that.
And then one person has a question about the functional MRI that you were talking about. How can we be sure that parts of the brain that are active simultaneously are talking to each other?
Yeah, so that's a very good question, actually. So essentially because you can't ask the parts of the brain if they're talking to each other, you have to use markers, just like we use markers of liver disease or whatever. And essentially how functional MRI works is that the brain cannot store energy. Right? So like muscles and things like that, they store energy and they use that energy. The brain can't. So the only way that brain gets energy is by increasing the flow of blood to that area that needs it. So when a part of the brain is active, it needs more blood supply to come there to deliver the energy to it. So what functional MRI does is it's not actually looking at nerve cells acting. It's actually looking at changes in that blood flow control. So basically the signal it gives out is the areas of the brain that, I guess, think of it as opening up the gasket for blood supply to that part at the same time as the other areas. And the brain does not open up the gasket if it's not working. It keeps it very well controlled because the brain uses a lot of energy, and so it can't all be firing at the same time. And so that is very tightly controlled in our body, in our brains, and so that's the presumption, and it's a presumption, is that those areas are acting in synchrony if the brain decides that they should be fired at the same time, especially if there's nothing driving it except, like, a lot of the MRI that we do is resting state, so you're just resting, you're not doing anything, it's not task oriented. I think the stuff that mouse thing I showed, That's nerves firing. So that's different, because you can do stuff in mice you can't do in people, where you can actually look at the nerves, use markers to look at them firing. I think it correlates pretty darn well with what you would see in functional MRI, where you see the areas that you think should be active become active, and then they talk to another area and it becomes active because they are in sequence, and then the other area and it becomes active. So it all makes sense, and it seems to, and this, believe it or not, that mouse thing took about 10 years to do, and it's like labs all over the world, and it's unbelievably sophisticated, and I show it in like 5 seconds or 10 seconds, but the reason why that's published in Nature is because that's going to really drive how we view how the brain does all this stuff, and I think it'll drive a lot of this stuff, how we understand how to do interventions to make people feel better, right? Because now we're starting to see what in real time, what's talking to each other in the brain, and then I think you can start to, as we get better pharmacologically or with behavioral therapies, we'll be able to target specific aspects of that we know are the symptoms that come out of that mistalking, basically.
And then in the last minute or so, I'm going to talk to Matt. So what advice can you just give to people about being in a clinical trial, and what's the most unexpected benefit that you've gotten in participating?
That's a good question. I think, it's part of the challenge is, of course, especially for the larger phase 3 trials, like we don't want to be in that third of the group that's on the control, right? I have a selfish motivation too to want to be on a drug that, even if it's just for 96 weeks, it's like, hey, is that going to help shift, my health span, so to speak? But there's the open label extension in these trials, right? So as patients, even if you're in that placebo group and you don't want to be there, at the end, there's the opportunity to be on that test drug. And then one of the other benefits I found is you get a pretty personal relationship with research coordinators, your physician, the principal investigator, sub-investigators, and sometimes like weird stuff's happened. I feel unwell, I'm not sure what's going on, and hepatologists, you guys are extremely busy. It can be tough to have that direct line of communication, but when you're in the trial, there's so many more levels of checks and balances that you get, I'm not going to say better care, but sometimes you have just quicker access to care because there's so many things they need to follow up on. So it's a good way to just, help keep that going.
I can build on that, actually, because I think that brings up a very good point, is when it doesn't even look at PSC, look at every disease. If you look at people that are involved in clinical trials versus those that are not involved in clinical trials, the people involved in the clinical trials, their outcomes are better. Why is that? Because they're seeing doctors and nurses and pharmacists and therapists all that time. Something happens, just like you said, you call them up. Like, you don't normally call up your specialist, but you can call up people in clinical trials. So there's that huge added benefit of being in a clinical trial, and it ties into what that, I don't know if people noticed in that when Michael Trauner was talking, there was the studies that look at people that are scheduled to come back for ERCPs, right? Versus not scheduled to come back for ERCPs. That was one of his graphs. The people that were scheduled to come back for ERCPs or regular surveillance, that's ERCPs basically, typically in that program, they did better. They go, wow, that's so interesting. Well, it's the ERCPs. Well, actually, the counter argument is it's not the ERCPs. It was the fact that we're going back regularly and seeing the doctor says, I just don't feel right. Whereas they normally would have no way of saying that, right? So there are tremendous advantages and disadvantages, but advantages of being better connected to the system, and depending on, like in the United States especially, where the healthcare system is somewhat fragmented, and depending on what plan you're in or whatever, your access to care might be quite different, and so clinical trials, I think, give you access that you would maybe not have otherwise, and it removes some of the socioeconomic barriers to getting that access. So I think there are a lot of upsides for being in a clinical trial. A lot of people say, I don't want to be a guinea pig. Well, it's different if there was a therapy that we knew was effective, right? But when you have a disease that doesn't have an effective therapy, then you can see the potential benefits of getting a treatment that might be effective, as long as it's not doing harm, but you're getting the benefits of being connected to a system that's going to find things earlier, usually, if it's a bad thing.
Steve,
Just a pitch, though, to that is the majority of patients don't have access to a clinical trial site. And you know, it's great that there are these expertise sites where they can get that care and be connected to a trial. But we have to start thinking about, and I know this from on the development side, in order to best serve the broader community and frankly make these trials go faster, we have to look at alternative ways to get patients into trials, supporting them through remote networks. We heard a little bit about that, but you know, patients can't drive they will, but is it a good outcome for a patient to drive 6 hours each way to get to a trial site? You know, what can be done to broaden who gets into a clinical trial? Because I think we see only a few hands come up, but that's because they don't actually have access as much as desired. I think so. We have to balance that as well.
Well, I think we'll end there. I want to thank the panelists. This has been a really enlightening session. And if I did not get to your question, I'm sorry, but you can approach the panelists at any time. They're all around. So thank you. And I think it's lunchtime now.